I'm going to talk about my, experience with the Javelin catheter. The first patient is a patient who's had a recurrent SFA stenosis. I think we are dealing with this for the third time. So I'll show you our initial. She has very short distance claudication. We had a duplex ultrasound. You can see she's not been stented. We have a super tight recurrent lesion in her SFA. So the options are, kind of re-intervene, and I try to do everything endovascular as long as possible, because at some point, if they need a bypass and you delay the bypass, you really prolong the patency of the bypass or whatever else needs to be done. So this is a diagnostic angiogram, and you could see multiple areas of high-grade stenosis. Some of them look like a string sign right there. So my thought was to try to get through this, and some of them, it's hard to get through. So for when I see a very tight lesion, I tend to use an 014 wire and the Javelin catheter to kind of help get through without causing a dissection or any trauma. So I usually get the wire barely out of the Javelin catheter and advance the catheter along with the wire. Now you can see this is a road map, so it looks like a different color. And the dark spot here is the tip of the Javelin catheter. I have an 014 wire. I think I'm using my go-to wire is an 014 glide track. So I assume that's the wire I have here. And you can see I'm trying to advance the wire through the lesion. And this patient, actually, we could not advance the 014 wire easily. That was kind of stuck right there. So you park it right where the 014 wire doesn't cross very easily. You start pulsing. We get about 10 pulses. So if it goes through very easily, I will continue to move. For a larger vessel, I don't necessarily use the Javelin as a standalone lithotripsy catheter. For a larger vessel, I think we will have to go back with a larger balloon. If this is tibial, I tend to move much slower. So you can see that's after our first pass. And we have passed this. I was able to get through it with the help of a Javelin catheter without needing to J the wire, without causing a subintimal plane, which is kind of very important. So just with the Javelin, you can see with the angiogram, we have about a 30% luminal gain. So it's done some work, but it is a much larger vessel than the Javelin catheter for typical SFA. So typically following this, I'll run an intravascular ultrasound, and depending on the diameter, I may decide what my next steps would be. So here, it's a reasonably sized vessel. So I tend to do an intravascular ultrasound on all patients. I don't have the IVUS images, but you could, even on the plain fluoro image, you can see visible calcification. So this was a very calcified vessel. So we are following this with a 5mm E8 balloon. I tend to size it from intima to intima. And this is, remember, a third time recurrence in the SFA. So I follow that with the DCB. We did have very brisk flow, but you can see there are small areas that looks like, maybe little non-flow limiting dissection. But when I have multiple recurrences, I tend to stent them. So I've here used a drug-coated stent. I stented the whole area, and you can see the completion angiogram looks pretty good. Typically, if it's very calcified, I will follow with another shockwave balloon and a DCB. That's my typical algorithm.